Okay, welcome back. So we'll go ahead. I'm not going to do an introduction. So I think it looks like that everyone was in the first session. So we'll just go ahead and Lisa, thanks again for coming back and doing part two. So we'll let you go ahead.
Sounds good. I'm going to share. So once I start sharing my screen, I can't see the chat, but I'm going to share a link to our social press kit that we have that I will talk about a lot presentation. So thank you all for coming back. It seems like we were able to retain many of you. So thank you for coming back. The first one we talked more about, COVID itself, SARS-CoV-2, talked about some vaccines and talked about different prevention strategies. And really in this next session, we're going to talk about what we've learned here specifically in West Virginia and talk about vaccine confidence and also talk about what is vaccine hesitancy and then provide some of the resources that we have available at a state level that many of you could use in your school settings or in your own networks if you get questions about COVID-19 vaccines. So I'm going to again share my screen. Let me know if, Carol, you can let me know if you're able to see these.
Yes, we can.
All right, so we're going to talk about data-driven communication strategies in West Virginia when it comes to COVID-19 vaccines. As I mentioned in the first talk, for those who might be joining us, I'm a pediatrician by training. I've always had an interest in communication, and I knew since I've been working since last August on the vaccine rollout that it would be really important for us to have a robust communication plan in West Virginia. As a pediatrician, I talk about vaccines all the time. And here in West Virginia, we really took an approach to understand what are people's intentions and perceptions and beliefs when it comes to vaccines, and then how could we provide information to them. And so I work with a really dynamic team of whom are listed here. A lot of unsung heroes doing a lot of work behind the scenes. Elaine Darling, who works with the Center for Rural Health Development in the West Virginia Immunization Network. Many of you may work with her. Dr. Julia Frostino, who leads the Public Interest Communication Research Lab at West Virginia University that we'll talk about. Major Holly Nelson, who is the Strategic Communication lead for the West Virginia National Guard. And then Dr. Daniel Totske, who also works in the West Virginia Public Interest Communication Research Lab and is a health communication scientist. And so I, again, have no financial disclosures. Here we're going to talk more about what is vaccine hesitancy and confidence, and then how can communication science help us be effective communicators when it comes to COVID-19 vaccination, and then how can we apply some of those strategies, whether it's patients or maybe those around us. And so here is a little bit of an outline. I'll go right through. So this is a quick refresher. If you weren't able to participate in the first session, we went into more in depth about the vaccines, but right now there are 3 authorized vaccines for COVID-19 authorized for use in the United States: mRNA, Pfizer, and Moderna. Again, that provides a small piece of material with instructions on how our body can make the protein for the virus, so that if we come into contact with the virus in the future, we're able to fight it off. The viral vector vaccine, which is the Johnson Janssen product that's authorized for use in the United States, it contains a modified version of a different virus, and inside of that is a piece of material, how to make the virus that causes COVID-19. And so this then tells the cells how to make the protein for the virus. So again, right now, Pfizer and BioNTech is authorized for use for 12 and above. Moderna has submitted its data and has asked for authorization for use for ages down to 12-year-old. We're still waiting for the FDA to grant that. Currently, those 2 vaccines are a 2-dose series. Pfizer is 21 days apart, Moderna 28 days apart. Johnson & Johnson Janssen currently authorized for 18 and above 1 dose. I didn't mention this in the first talk, but one of the more recent recommendations from the Advisory Committee on Immunization Practices, which was a shift from in the beginning, is that in the beginning of the vaccine rollout, it was recommended that there's no co-administration. So you'd have to wait 2 weeks to get another vaccine. This was obviously something concerning for pediatricians, because we give multiple vaccines in the youth period and in the teenage years. And then also for even adults, we had many cases of an individual falling and needing a tetanus shot, or getting a tetanus shot, or a pneumonia shot, or the flu shot. And so the recent guidance is that the vaccines are able to be co-administered. So there's no longer that wait period. So the vaccines are able to be co-administered. It is recommended, if you're giving more than one vaccine, to put them in different locations or different arms, ideally. And so we continue to learn more about these vaccines. So that was a really brief background. And if you were a part of COVID-1, we talked way more about the vaccines that are for use. So we're really going to shift our talk now and talk about what is vaccine hesitancy, and really how can we shift this conversation more to talk about vaccine confidence, and how can we build vaccine confidence in the public. And so the Strategic Advisory Group for Education, the SAGE Working Group on Vaccine Hesitancy, this is what they define vaccine hesitancy as. So it's a delay in acceptance or refusal of vaccination despite availability of vaccination services. It's really a complex and context specific. It varies across time, place, and vaccine. So an individual may be willing to get one type of vaccine, but not another vaccine for different reasons. Some individuals may not want to get vaccines at all. And so it really does vary. And there's a lot of different factors that weigh into someone's ability to accept or to outright refuse vaccine. And so there could be complacency, convenience, and confidence. So there's many different factors that impact vaccine hesitancy. But really what our team has been trying to do, and we've seen this when we've advised CDC, HHS, the White House, is really, how do we shift this conversation to more about vaccine confidence? And really, how can we work to build vaccine confidence? So this is the extent to which individuals are motivated or willing to get vaccinated. It is also complex and context specific. So I talk about this all the time. I get asked, what are the most common reasons why people don't choose to be vaccinated? For individuals who haven't chosen, there's as many reasons as there are individuals. It's really individual based, although there may be some overlap. It really is, it differs for each individual. So it also varies across time, places, and vaccines, and really gets influenced by perceived risk, access, the safety and effectiveness, and really the opinions of important others, which those of you who are in healthcare listening in on this, you are the trusted voice. So healthcare professionals, particularly local health professionals, that's wide ranging. So individuals that work at the front desk of a healthcare setting, to the provider themselves, working in that healthcare, that broad outreach, are seen as trusted sources of information for the community. So really plays an important role in addressing vaccine confidence. And really, when we talk about vaccine acceptance, it's a continuum. So as you can see here in this graph, there are individuals who will just outright refuse. It will not matter what information we provide, what science, evidence, personal experience. They're just individuals that are absolute refusal. Retired General Hoyer, he always refers to this group as the hell no's. These are individuals who absolutely, will refuse vaccination. Then you have the other end of the spectrum, which is where I probably personally would describe myself, which is, I trust the science. I trust the process that individuals go through. And, I certainly, as soon as the vaccine was offered, I chose to be vaccinated. And then you have this whole big middle section. And so this is the individuals who may have questions. They take a wait and see approach, I'm going to wait and just see how other people's do, or they really want more information. And so this is a pocket of individuals that we call, the movable middle, or the persuadable public, or however you want, the fence sitters, however you want to kind of refer to this group. It's really a large amount of individuals that they're just they need more information. And this is where, as healthcare providers, for those of you who serve in a healthcare role, can really play an important role in in building vaccine confidence. And so we knew that this was going to be a challenge from the beginning. We all should be trying to boost vaccine confidence. So back in October 2020, so 58% of the general public said they would receive a COVID-19 vaccine. And these were some of the factors that weighed on their acceptance. Was there side effects? Does it work? Is it safe? And how much does it cost? We have seen in our data in West Virginia, which we will talk more about here in just a little bit, that these have persisted throughout, that individuals continue to have these questions, and those are the answers that they want in regards to choosing to be vaccinated. And so, really, when we looked at, kind of the national challenges, how can we increase perceptions of acceptability? And so COVID-19 vaccines would seem to be more acceptable if a healthcare team member said it was safe. It was free, so no cost to the individuals. It would help us get back to school and work. So we hear that a lot, that individuals, want to choose to be vaccinated so that they can get back to doing those regular activities. And then also if they could get it easily. So there's a lot of factors that go into getting vaccinated, the hours of the vaccine clinic, when you work, are you able to work that in? Do you have childcare? So there's a lot of other factors that weigh into someone choosing to be vaccinated. Also taking into extent if you do have some of those side effects and that you may not be able to work or not feel up to going to work, how does that play in as well? So what about here specifically in West Virginia? So what are some of the vaccine perceptions, beliefs, and attitudes that we see here in West Virginia? So I talked about this a little bit in the beginning. We really wanted to have a better understanding of what do people in West Virginia want to know when it comes to vaccines. So the state worked with the West Virginia Public Interest Communication Research Lab. It's housed in the Reed College of Media at West Virginia University. Dr. Julia Frostino and her team. Really, this lab merges theory and practice, looking at developmental implementation and evaluation of science-based strategic communication efforts to achieve and sustain a public's attitude or behavioral changes regarding a public health issue. So they do work in many different areas, advocacy, crisis and risk communication, science communication. Really, the lab's goal is to use social science for positive social change. And so, here in West Virginia, we knew that we had a high task ahead of us. The emphasis of the importance of vaccination was stressed from the beginning, from the highest level. The governor, we knew that West Virginia, and here's a graph of the Kaiser Family Foundation back in April of 2020 that put West Virginia as the state with the highest amount of adults at risk for serious COVID-19 illness. We know that our state does tend to rank among the lowest when it comes to health. And we have a really rural state. So we have a population of about 1.8 million. We're spread out. So, the population of our state is about the population of Phoenix, but we're spread over a vast rural landscape. And so that can create some logistical challenges to ensure that we're providing access when it comes to vaccines. And also we can see regional differences in intentions and beliefs and perceptions to be vaccinated. So as I talked last talk, West Virginia chose to have a joint interagency task force on COVID-19 vaccines that was established by Governor Justice. Has many different members, including DHHR, National Guard, Higher Education Policy Commission, Department of Education, West Virginia University. And then within our JIADF, we have what we call the Joint Information Center, which is where I spend most of my time. And so this is led by Major Holly Nelson, who I mentioned at the front, and we have many different members represented on our Joint Information Center. But really what we have seen throughout this rollout is it really takes partnerships for coordinated communication. Our goal since before a vaccine ever arrived in West Virginia was, how can we provide clear, consistent, scientifically sound information so West Virginians can make an informed decision for themselves and their families. So as we talk about that vaccine acceptance continuum, really there is individuals that they need more information. And so as a Joint Information Center, we were tasked with how can we get information that is able to be easily consumed and understood by individuals. So we really felt it was important to understand what do people want to know. And then from that, we developed evidence-based messages to address individuals' perceptions and beliefs. And this was all possible through a grant with the CDC administered through DHHR. So in West Virginia, we really wanted to understand these beliefs. So we took the approach of a mixed method social science. We did both quantitative and qualitative inquiry. Many of you may have participated, so if you did, thank you. We did quantitative inquiry, so we did statewide surveys. So we were able to do surveys before a vaccine ever was authorized or ever reached West Virginia. We did particular population surveys. So if we saw areas with lower uptake of vaccine, we would go in, do a survey, understand what do people want to know, and then we would provide information to them and hopefully improve vaccine intention. We also did qualitative inquiries. So we did focus groups, in-depth interview, key informant interviews where we would talk with members of populations. We worked with extension services to do qualitative inquiry around the state, where we even tested messages to see how that would resonate with individuals. And we continue to adapt. So I can tell you that this has been a very ever-changing process, as there's new guidance that's given by the CDC, new vaccines get authorized for different age groups. There may be a report of a side effect like we talked about last time with myocarditis and pericarditis. So we've continued to adapt our data collection across all phases, and then use behavioral change theory as well, and always take advantage of resources available through the CDC, HHS, and our other national partners. In West Virginia, we formed a statewide communication group, and it was really helpful to have representation from a variety. This is not an extensive list, but we tried to reach out to many different individuals who we knew were trusted messengers, and to be able to have outreach and then provide a coordination through partnerships with them to be able to provide that clear, consistent, and scientifically sound information. We also have a medical advisory board that's comprised of different health experts across the state of West Virginia. So we always had whatever documents we would create be run through our medical advisory board to make sure that we were representing the science to the best of our ability, hearing from individuals on the ground, so health officers, individuals that work in infectious disease, critical care, nurses, pharmacists. So really, are we understanding the vaccine science, and are we articulating that to the public? We worked with a West Virginia-based media company, Digital Relativity, based out of Fayetteville, that helped create. We're going to see some of their graphics and a video, hopefully, if I can get it to play. And then really, we always translate the insights into tailored and targeted messages so that we're able to deliver content to individuals from a messenger they want to receive it in the channel that they want to receive it from. And so really, this allows us to create messages that resonate with an audience self-interest so that we can get it to them how they want to receive it from messengers they find credible and trustworthy. And we always do this through a lens of health equity, trying to promote health equity. And we always want to be culturally responsive in our language and also promote verbal and visual inclusivity in all of our different materials. So let's talk about some data. So I mentioned that we in West Virginia did assessments before a vaccine was ever authorized for use. So we did a baseline quantitative statewide survey. We currently are in our third wave. So we have a survey out in the field now. And what we found at baseline, so November to December, we collected all this data before a vaccine was authorized for use. And what we saw was that 43% our sample, which was representative, it was we had representation from all 55 counties, that 43% were strongly planning or somewhat willing to get vaccinated. 12% were neutral, unsure, 25% were less willing, and 20% were really on that far end of the spectrum, the absolutely not, strongly unwilling to get vaccinated. When we did our second wave of the survey in March, which, to note, this was primarily before J&J, if people remember, J&J did a brief pause when they were looking into thrombosis associated with J&J. So there was a brief pause of the recommendation of use of that vaccine. And what we found in that survey is that there was an improvement, and we have data that shows statistically significant for individuals who saw resources that we developed through our community immunity campaign, that 52% were then strongly planning or somewhat willing to get vaccinated. 10% were unsure, 24% were less willing, and then 14% strongly unwilling to get vaccinated. So we did see a shift, an improvement in intention to be vaccinated, particularly if they had seen some type of resource. So going back to what we've talked about with this vaccine continuum, many people just need more information. They have questions, they want answers. And so as members of the healthcare community, that's part of our role to provide those answers to them. I think important for those who work with children is parent intention. So we have a completely different survey that is just finishing up that looked at parent intention solely. So individuals who identify as having someone 18 or under being the parent or guardian of them in West Virginia. But this data goes back to March, and this was basically the intentions of West Virginia parents or guardians to vaccinate their children. Very interestingly, it's very similar to the numbers we saw if we go back a slide to our baseline data. So 39% were strongly planning or somewhat willing, 70% were neutral, unsure, 20% were less willing, and 20% were strongly unwilling to be vaccinated. I don't have a slide, but I can tell you what our most recent data is showing, that individuals who have not yet chosen for their children to be vaccinated, over 90% of them themselves did not choose to be vaccinated. So probably doesn't come as a big surprise to many who are watching this or who, have been involved in vaccine clinics. But what we're seeing in our parent data is that, parents who don't choose to be vaccinated, they don't vaccinate their children as well. So I think that's important when we're moving forward in this vaccine rollout and vaccine initiative, because I always, as a pediatrician, want to remind people, like, make sure we're talking to the patient, which is the child or the teen themselves, but that it's also important to provide education to the parents, because in West Virginia, the parent is primarily still making the decision. And we have seen, I think the Department of Education has done focus groups even where we've seen students say, I want to be vaccinated. Can you convince my parents to let me be vaccinated? So in West Virginia, it still is a consentable, the parent has to give consent for the child to be vaccinated. If anybody's been following the national news, Tennessee, I have to say I'm very good friends with the top vaccine official who was terminated, Dr. Michelle Fiscus. There's been a big debate here recently in Tennessee that their legislature said that, they felt it was gross overreach. It was basically an explanation of that state's law of a mature minor doctrine. Now Tennessee has taken a really aggressive approach to not do any education about any vaccines. So to any teenagers, so not just COVID, but any vaccines. Certainly, as a pediatrician, that gives me significant heartburn, because certainly we need to be educating about the importance of vaccines and vaccine preventable diseases. We already saw a decline in vaccine rates because of the pandemic that puts us at risk to have outbreaks of these very preventable diseases, but it is somewhat worrisome. So those who are involved in school health know West Virginia, we have strong immunization policies where we only permit medical exemptions for school entry. So we do have required vaccination for school entry and strong immunization policies that really puts us at the top when it comes to vaccine policies. And many states model our legislation, and we've been fortunate to not see outbreaks of measles or other vaccine preventable diseases as other states have. But certainly everyone's kind of keeping their eyes on Tennessee as we look to see as we move forward, and different legislatures put requirements or stipulations into place. Certainly we want to, I think, make sure that we're providing evidence-based and science-based information, but certainly an upward hill to climb I'll just end there before I go more about politics and public health. But I think it's really important when we talk about parents and guardians and their intentions when it relates to their children, so that we're providing education to all the individuals involved. So from this, what we have learned, and this is kind of a summary of what are the main things we've found through this. So what we have seen is that individuals really want to know about the vaccine development process and the safety and effectiveness. So in COVID-1, we talked about the safety and effectiveness of the vaccines, but to this day, this is a common question I get, like, are these vaccines safe? Are they effective? What we have seen across all ages, demographics, races, ethnic demographics, is that short-term and unknown side effects is what people want to know about. That is their concern. They want to know, are there short-term or long-term side effects? They also want to know, how effective is it at preventing severe disease? So if I choose to be vaccinated, am I going to be protected? It's also important in our messaging that we showcase motivating benefits. So in much of our messaging, you'll see it's protect yourself. So we have a group of individuals that, they get vaccinated because they want to protect them. But we also have a whole other group of individuals that they get vaccinated to protect others. And really, we've seen this consistently, that people want to get back to living their regular life. So showcase motivating benefits. So those who work with high school students, a motivating benefit may be you get to participate in your sporting event, or you get to go to prom, or you get to go to something that you've missed. You get to have a homecoming dance, which was something that they missed. So that's like a motivating benefit to get vaccinated. We also want to message about removing barriers or perceived barriers. So an earlier slide, even nationally, we saw that individuals were worried about the cost associated with the vaccine. The vaccine itself is free. The United States government, they bought, I can't even countless numbers of the vaccine doses. So the vaccines have been provided for free. Different sites can charge an administration rate through insurance, but that is payable and not at all should fall onto the individual. So the vaccines are free. It's also important to remove barriers about access. Even now, still are seeing in our data that people don't know where to get a COVID-19 vaccine. Some of you might chuckle at that because we've seen many TV commercials, social media ads. There's been a lot of different outreach, but there are still individuals that they don't know where they can get vaccinated. And so we really have to continue to work on sharing the message. One of the common things that we've seen more recently is people still think they're not yet eligible. So in the beginning of this, when vaccine supply was very limited and that it was, based upon those at higher risk, and so they were given to different populations until the supply expanded and we were able to offer to more and more individuals, there are still people who think that they're not yet eligible to be vaccinated. And so that continues to be a message that we have to relay. So for Pfizer, those 12 and above are eligible. For Moderna right now, it's 18 and above, as well as for Johnson & Johnson, 18 and above. And then also something that we've seen consistently in our messaging is the importance of underscoring hope, optimism, trust, and confidence in the process. So really, this has been a hopeful time. We, back in December and January, we were starting to see really high rates of hospitalizations, high ICU numbers. It was really a critical time. And thankfully, due to kind of the effective rollout that we had, reaching the higher risk population first, vaccinating them effectively and efficiently, and seeing good uptake in that population as well, we were able to see a significant reduction in deaths. But really, really underscoring the hope and optimism. I know that's something that I personally saw. Just my colleagues, friends on social media are telling me, just how much hope that they felt. I certainly personally felt that as well. And what we've consistently seen throughout is the importance of relatable, local, trusted experts and opinion leaders, which many of you on this call are. So you're trusted members of your community. People trust you. They ask you for your opinion and they trust it. And so that's an important role that we play. And what we have seen consistently, it's really local, local, local. Individuals want to hear from people who look like them, sound like them, know them, live in their community. And we've really done this down to the word choice level in West Virginia using the data. So we saw very early on in our data that people would not attend what they call a mass vaccination center. So if you did this right now, like if we took a pause, if you all did this, so fill in the blank, mass blank, fill in the word with anything, mass blank. What would be the first three things that come to mind? Usually people fill that with negative connotations. So they say mass suicide, mass genocide, mass incarceration, mass shootings. So it's a negative impact. So they relate that just as a negative connotation. So there were individuals who said, I would never go to a mass communication or mass vaccination site to get vaccinated. So in West Virginia, we use the word community. It fit with what our theme has been, community immunity West Virginia. And so we have really emphasized the importance of talking about community vaccination clinics or events so that we can remove that negative connotation of mass vaccination. So what about for specific populations? So we talked about we always want to be advancing health equity. So when it comes to messaging considerations for Black and African American West Virginians, it's really important to acknowledge questions that they have and that they have caution that's rooted in historical realities of medical and historic racism. And so to them, it's sensitivity to perceive threats to their freedom and choice. So this is going to be a theme that you see consistently in West Virginia about choice. And then they really feel pressures of being vaccinated. They feel like they're getting pressured to say, like, you have to be vaccinated. They find a lot of trust in faith. So another consistent thing you'll see is trust in the faith-based community and also family. And I already kind of said this, but really in this population, they want trust in local people and people who look like me, talk like me, sharing their stories. When it comes to Spanish-speaking West Virginians, they tend to use mainstream media, but they don't really tend to trust things like Facebook. So they may be on Facebook, but they don't necessarily trust what they see on there. This population tend to trust more CDC and top medical experts. And then they really do trust science, again, faith, family, and then this population really trust pharmacists. So in many Spanish-speaking countries, pharmacists play a very central role and many times are the leader of the healthcare team. So they prescribe different medications, they give medical guidance. And so really this population really trusts pharmacists. And then what we saw is that they really want fact-based information. So they don't want a spin, they just want the facts, but they want it from Spanish-speaking community members and they want Spanish language documents. So we have many resources that are available in the Spanish language, including a Q&A for 12 and above or parents who care for teenagers, because we understood the importance of Spanish speaking. And when I share some examples of our different messaging techniques in West Virginia, you'll see different graphics that we chose were to address questions specifically that Spanish speaking West Virginians had. And then for considerations for white conservative West Virginians, it's really, they have sensitivity to perceived threats to freedom and choice. And so if you've heard me give this talk throughout, I've talked about people choosing to be vaccinated. And so I'm very intentional in saying that this is a choice. We want to be able to provide the information for individuals to make an informed decision, but at the end of the day, this is a choice. They too want unbiased apolitical messages. They just want the facts. This particular group has seen a declining trust in national federal government sources, which I think probably doesn't come as a surprise to many people, but I think that we've seen that time and time again, that there's a declining trust in our national entities. But they, again, trust in local people sharing their stories, and they trust in the faith-based community. So you can see these consistent themes that we've seen: choice, faith-based community, local. So how have we been able to implement this communication approach? So I already shared the social press kit in the chat. I also encourage people to go to vaccinate.wv.gov. We have the vaccine info line, which I mentioned before. We have a FAQ that's available on the website along with a communication toolkit. The social press kit, the link I shared, if you check that out, it has already crafted social media messages that you can share. It also has different printables. It has stickers, which as a pediatrician, I love. We also have had customizable billboards. We held a series of town hall. We've had PSAs, which I'll show you a little bit of. We've had local ambassador journey videos. So we had a variety of local experts share their vaccine journey. So before they got vaccinated, to getting vaccinated, to after, and how they felt. And then we also have designed tailored collateral. So for instance, we saw a lower uptake in our Department of Correction. So we went in, worked with the Department of Correction, and tried to understand what type of information do people need. And then once we understood what that was, we were able to look at that data and then provide them with resources that they could help make a better informed assessment. We continue to do this work. It's really an ongoing. As I mentioned, we just recently completed a parent survey as we knew that 12 and above would be eligible for vaccine, and we anticipate younger populations. What type of information do parents need to make that informed decision? And then we'll continue to look at overall intentions of all West Virginians as we continue to progress through this vaccine rollout. So I'll just share with you now just a few examples that we have. So very early on, our key message was safe, effective, trusted. So we saw this consistently throughout data of what individuals wanted to know. So here you can see we have information and then a link back to our website. Again, vaccination is the safest path to community immunity. So community immunity has been our theme, or kind of what has been our group. This whole mantra that community immunity begins with me, and really that it's the safest path. So we frequently hear sometimes people say, oh, well, I had COVID-19. Well, we don't know how long natural immunity will last. And actually what we're seeing is that individuals who get vaccinated have much better immunity, and those who've had COVID and get vaccinated, they have really good immunity towards COVID, the vaccine that causes COVID-19. Here's what I said before, community immunity begins with me, which has really been our kind of from the beginning. And then here where I talked about how we translate different items to the Spanish-speaking population. So talking about wearing a covering, staying apart, washing your hands, and then choosing to be vaccinated. Here's another example. So one of the items we saw in our Spanish-speaking communities was the concern for cost. So this graphic talks about that COVID-19 vaccines are free. And then as a pediatrician, it was going to be one of my goals to make sure that we had stickers. So this is a sticker template that you can access to get vaccinated. This is the vaccine sticker that Governor Justice received. You can see here, this was the CDC sticker, the orange and green sticker. The CDC launched that sticker. We adopted that in West Virginia to make it have a West Virginia approach. There's been other stickers that I've seen, but I think hopefully this group is friendly, since we all care for kids, how much we all love stickers, and I still have it on my cell phone, my vaccine sticker. Really throughout our response, we've focused on our vaccine priorities. This was particularly important in the early phases of the rollout when vaccine supply was limited. So our priorities were to protect the most vulnerable, reduce deaths, reduce hospitalizations, and maintain critical services in acute care. And we really went back and emphasized in the decisions that were being made as to who were get access to the limited supply of vaccines. And we always tried to emphasize that, we would recommend choosing vaccination when a vaccine becomes available to you. And now, as I mentioned earlier in the last presentation, vaccines are really now widespread available across the state and across the country. Globally, we definitely have a lot of work to do, and certainly need to see better vaccination in other countries, as we talked about in the first session. This pandemic was spread through global travel, and so it is really important that we keep an eye about what's happening in the rest of the world, particularly when it comes to variants and vaccination, and getting able to vaccinate the whole global community is going to be important moving forward. So here's just some data-driven strategies that I thought I would share with each of you, perhaps if you get asked questions by parents or your patients. And so what should you do when you're talking about COVID-19 vaccines? It's really important to start from a place of empathy and understanding. Ask them, what questions do you have, or what information do you need? And then it's really important to know that it's probably going to take more than a single conversation. I see more and more reports of individuals saying, I've talked to individuals 5, 10 times and they finally chose to be vaccinated. It is important for us in healthcare that people do respond to a strong recommendation. So when I'm talking with patients or parents for that matter, I say, I strongly recommend that your child get a COVID-19 vaccine, or I strongly recommend that you get a vaccine. This shot is especially important because of your underlying, you have a compromised immune system because of your rheumatoid arthritis. Or, and I've said this one too, I believe in the vaccine so strongly that I got vaccinated as soon as it was available to me, and I ensured that everyone in my family did the same, which, that is certainly a statement that I have said. And then really listen and respond to the questions they have. Here's some different resources that are available to help you answer those questions. So at vaccinate.w.gov, or on the CDC site, there is a list of commonly asked questions and recommended answers so that you can go there. If you haven't already checked it out, I recommend that you do. It has a list. I think we have well more than 30 or 40 questions of the most commonly asked questions that can help give you some guidance. And then really close the conversation with openness and a call to action. So maybe they won't choose right then to be vaccinated, but maybe they can go and look up more information, or you can provide them with that information that they can then get. So what shouldn't we do when we're talking about COVID-19 vaccines? I know this is super hard, and I have personally, struggled with this, and I always talk to my colleagues about this, but it's very important to not repeat the rumors or misinformation. So even individuals with the best of intentions, when you repeat the rumor or misinformation, you're actually propagating that. And so although people may say that, so a question I frequently get is about, I'm going to again break the rules. There's been a lot of questions about infertility. I approach the question as, the vaccines are safe for individuals who are planning to get pregnant. So I don't even use the word infertility. And I talk about, the vaccines have been studied and there's ongoing monitoring, but there's, no reason and we have no indication to think it will impact a person's ability to become pregnant in the future. And so it's really important to not repeat those rumors or misinformation, because even though we don't think we are, we're actually propagating that myth. And so if you're responding, if the negative is false, the positive is true. So always framing positively. So like what I did there, instead of talking about infertility, I talked about someone's ability to become pregnant. And so it's really important to talk about like yes and instead of always talking about but, like, because people, as soon as they hear but, it kind of goes back to that negative connotation. So again, being open. And it's really important to not use fear, guilt, shame appeals. It's a really delicate balance. I think a lot of times we talk about shaming people or guilting them in. That really, time and time again, does not show to be effective. And so we really have to be cognizant of that and mindful when we're talking to patients or talking to people, because as I showed before and what our data has showed us, people want unbiased, science-based, apolitical information, and they don't want to be guilted or shame appeals. And so you have to be avoid that persuasion or even just the perception of it, and really share the facts. So this is the information I have, this is what I'm sharing, this is the research I've done, and this is the information that I can provide. So here are just a few other resources. I already mentioned some of these. CDC, HHS, the AAP, the American Academy of Pediatrics. Full disclosure, I'm the president of the West Virginia chapter of the AAP. I also serve on the National State Government Affairs Committee for the Academy. There are many different resources that they have available for parents as well as for teenagers for this population that I recommend you checking out. And then I just wanted, I don't know if this will work, but I wanted to show a video of what we did for using our data to try to help improve vaccine intention. So let me see if I can get this to work. I'm gonna share my other screen and see if I can get this to work. Okay. So, Carol, are you seeing a video or a YouTube screen?
Yes.
Okay. All right. Well, we'll see if this works. I don't know if the sound will work, but we'll give it a try. So this is one of the videos that our team put together.
Hey guys, it's Cora, and today is a pretty big day because I'm getting my second vaccine. I'm a little nervous, but the first one was fine, and it's for a really good reason. Hey guys.
So hopefully you all were able to see that, but that was just one of the videos that our team put together. And I think that to this group, I will say, for people who have been involved in vaccine efforts, how many hugs have you helped promote, or how many people have you helped get back to living regular life? Maybe it was counseling them to help them make an informed decision or actually, participating in vaccine administration. It took, and it continues to take, a whole of community approach, an all hands on deck team approach. And so, I think each of you, you probably don't get the praise that you receive. Certainly, I don't feel like you do, because I know how much school nurses, school personnel impact the lives of children and families every day. So thank you again for all that you do. And when it comes to vaccination, you certainly are a trusted source of information and have played an incredible role, and continue to play an important role in our vaccine efforts. So we'll just finish out this presentation, and certainly want to make sure that you can ask any questions. Just in summary, we currently have 3 authorized COVID-19 for use in the United States. Vaccine confidence is important to build, and we each play a role in that, and especially among parents, as we're seeing more, that it's going to be important that we work to build confidence, particularly in individuals who they themselves have not chosen to be vaccinated. And then really key considerations, a strong recommendation from a provider is essential. Judgment-free, empathetic communication is most effective, and really continue to emphasize choice. And then you now hopefully have access that I've showed you, and I'll share the other link in the chat to some data-driven strategies and resources to talking to patients. Here's my email address, and I will yield it over to you, Carol, to address any questions. I think I've seen a few individuals who have some questions. I'll be happy to address them the best I can.
Yeah, again, if you want to just write it in the chat, you can do that.
Yeah, so for the comment in the chat about individuals who work in the hospital, it's an excellent point. So our uptake rate among individuals who work is not the best. This is also true nationally. And that's somewhat concerning, right? Because I just gave you this presentation talking about how people trust local health professionals. And so they are kind of twofold. They're important for, obviously, they're in a higher risk environment, so they're exposed to people who, or care for people who have COVID-19. They're around immunocompromised individuals, but then also they're trusted sources of information. And so it is really important, and we've been talking at a state level of how do we circle back. So, healthcare professionals were offered vaccine very early in the rollout, back in December, January. And so really circling back and doing additional education and resources. You do see people that just said, hey, I just want to wait and see. And we actually saw that even early in the rollout. There were people who initially said, no, I'm not getting the vaccine. Once they saw like other people on their units get vaccinated, they were like, I want to get vaccinated now. We saw the most uptake of vaccine in units that cared for people who had COVID-19. So particularly ICUs, I think people who saw the devastating impact of the disease itself. I think what happens with vaccines and becomes super challenging is we become almost a victim of our success. So we start to see less disease because people are vaccinated, and then people think perhaps not as they should that, the disease is gone or it's gone away. No, we're just better at preventing it. So the diseases still very much exist. And so it is important, that we do start also talking about the severe impacts of COVID-19. We talked about that a little bit in the last hour, but it is an ongoing challenge. And what I would say is, I think for individuals that have those who are on the less confident side of the vaccine acceptance continuum, is that it's going to take more than one talk. Sometimes it takes their time. We have heard from some people that, once the vaccine gets full FDA approval, they'll choose to get vaccinated. I think that we'll see that as time goes on and we learn more about the vaccines and the vaccines continue to show their safety and effectiveness. But I think giving the fact-based, evidence-based information that you have in an unpolitical way, is the best approach to take. But we know that there certainly will be individuals that, regardless what amount of information we give, they still won't make that choice to be vaccinated.
You have another question. Are students who need Tdap or meningitis vaccines or other vaccines for their age group may get them along with the COVID vaccine on the same day, but in a different arm?
Correct. That is the recommendation that came from the most recent update when ACIP met, when they actually authorized the vaccine for use in children 12 and above. It's just recommended that you give it in different arms because of the concern, if there is a reaction or a localized reaction, that you want to be able to address that. I'll drop into the chat. I think it's a really good site. I always look about it. It's called Clinical Considerations from the FDA, and they talk about co-administration with other vaccines, and it talks about they can be administered without regard to timing. So that was a change that was more recent, and it is helpful for individuals. So I just dropped that into the chat. If you go to the area that says co-administration with vaccines, you'll be able to see, and it talks about how they were initially recommended to be administered alone, but then after we learned more, the recommendation was that you can get it at the same day, as well as co-administration within 14 days.
Okay, another
Excellent question.
Sorry. Can
No,
a
go
fully
ahead.
vaccinated person carry and infect a non-vaccinated person?
So this is a great question. So as I said, I didn't, I think, quote percentages, but the mRNA vaccines we think are anywhere from even 95% effective. Now, again, they were effective at preventing severe disease and death. We've continued to learn more and more about the ability to transmit. The thought is that fully vaccinated people have very low transmission, particularly in children. We saw people who got vaccinated were very unlikely to transmit the virus. There is a small possibility that, and I think particularly as the variants come along and as we learn more. So we're seeing the Johnson & Johnson vaccine was deemed to be about 60 to 70% effective. For the variants, we're seeing that it could be, around that or a little bit lower. And so it does depend upon which vaccine you received. And I think I failed to mention in either talk, a fully vaccinated person is 2 weeks after the last dose in the series. So if you get, Pfizer, you get your first dose, you wait 21 days, it's 2 weeks after that. So it's a 5-week process. Moderna is longer, it's at least a 6-week process. And then, Johnson & Johnson, since it's a 1 dose. So really that fully vaccinated status is 2 weeks after the last dose of the series. So I think that's important when we're talking about, what for fully vaccinated, and we continue to look at populations like immunocompromised people to see how well they respond. So we know that their immune system is compromised. They're on medicines to, reduce their immune system. And so we're looking at and the federally and at state levels looking at the effectiveness of the vaccines in those populations. So it does somewhat. So I think it depends upon which vaccine you got. Certainly it's rare. And I can tell you what we've seen in outbreak clusters that we've seen. It's usually a non-vaccinated person brings in the virus. So whether that's in a congregate care setting, it's usually been started by an unvaccinated person and then spreads. And that there have been cases that, fully vaccinated people can still have a breakthrough case, but again, the vaccines were studied to prevent severe disease or illness. So although you may get COVID-19, you're less likely to end up in the hospital and much less likely to die from it. So you will be able to recover even if you do get COVID-19 after being vaccinated.
Okay, and well, if you'll send, I have your PowerPoint.
Yeah.
So if anyone wants a PowerPoint, I'm going to type in my name or my email so that you can personally email me, and I will get those out to you. Another question, since more people are getting vaccinated, do you think we are still going to have to contact trace and quarantine students this fall?
Excellent question, and this is something that certainly has ongoing discussion. I think the short answer is right now it depends upon the age group. Those of you who care for kids that are less than 12, they have not had the opportunity to be vaccinated yet. And so certainly they still possess that risk. Also, I think there's ongoing discussions about how do we know if someone has been vaccinated? So there's certainly self-identification of that. But do we know if a person's been fully vaccinated or not, including staff members? And so I do think that we're going to see, particularly this fall, potential quarantine and contact tracing occur, particularly in those who have yet to be vaccinated. But I think, we'll have to see what our vaccination rates, and certainly where the vaccination rates are higher, we would think that there will be less cases all together. But as we continue to monitor the variants, that's going to be something that we have to keep our eye on as well.
Okay, we may get questions about variants. Any suggestions on this?
Yeah, excellent question. So if you go to the social press kit, which I'll drop back into the chat, we actually have a couple graphics on variants. So what I can tell you from our data is that people don't know what variants are. So in our survey of parents, we did an open-ended question. When you hear the word variant, what do you think? The majority of people, they had no clue. If the few people that did describe it, they said it was like, oh, this is a different strain of the virus. So I've been trying to use it as that. Variants, like viruses, change over time, they mutate, they have different strains. Sometimes the strains can be they can cause more disease in certain individuals, even more so than the original virus. And so it is an ongoing question that I think we're going to have to address. But what we're seeing, at least in our initial data, is that individuals don't really know what variants are. So we talk about it a bunch, and we use this term, but really people don't understand what that means. So I think starting with describing what we're meaning by a variant, and then how that potentially could impact. And I think when it comes to talking to parents, it's important because we do think, and we have seen, that the variants do impact younger ages more so than the initial virus did. And so that's something that we'll have to continue to look into. But it's a great question. If you go to that site and you go to the social media post, we have some new comments on variants, so that hopefully that will help you address some of those questions that you may have as well. There's 3, they're kind of towards the end. And so it just talks about some of the different ways that we would suggest to kind of address talking about the variants. So there's some there, and we'll continue to update that as time changes. So I just dropped one of the suggested ways to chat about it into the chat.
Thank you. Another question. I've heard we might have to get yearly COVID vaccine boosters. Is there something we can expect with all the vaccines, or is it too soon to tell?
This is a great question. We had a whole discussion yesterday with Peter Marks, Sarah Oliver, who is the lead physician for the Advisory Committee on Immunization Practices, Dr. Atul Gawande. We've kind of participated in a statewide collaboration with them in West Virginia. And so it is a little too early to tell. As I said before, Pfizer had their statement that they feel like there will be a 3rd dose. The CDC and FDA right now feel that the 2-dose series is appropriate. I think we'll have to see how the variants pan out, and then we get a little bit more. What we're hearing more and more is that it's unlikely by the end of the year that there would need to be any booster. We're still determining of when that time may be. Is it after a year? I think we have to wait a little bit longer. And then I think a point that I'm still, digesting that was made was, in some vaccines, we learned that it might take 3 series. So, you get your 2 vaccines, and then you get one 6 months later. We see this very commonly in the primary immunization series. So, like HPV is a great example. So we found that if you get vaccinated when your immune system is a little more robust, you only need 2 doses, but after age 15, you really need 3 doses. And so as we learn more about, that was something that we found about the HPV vaccine after it had already been out and available. Originally, it was a 3-dose series for everyone. And then what we found, studying the virus more and more, looking at immune responses, we saw that if you got it when you were younger, so before age 15, you only needed 2 doses of the HPV vaccine to have the same immune response. And those above age 15 really needed 3 doses. So I think what we will see a little bit is, is there going to be a need for a COVID vaccine 6 months later or something like that as part of, our full vaccine series. So it may not even be a quote unquote booster, but more so just the series of the vaccine. I think we're still early to know that. And so however you refer to it as, whether it's just going to be like the series or a booster, I think a lot of people, when we hear boosters, we think of flu shot. So like every year you have to get a flu shot, and the flu is a little bit different because, each year we do change the flu vaccine based upon what are the most likely strains. We still don't know if that's going to be the case when it comes to COVID-19.
Any more questions? Okay, I don't see any. Let me double check in the Q&A just to be sure.
So there's a question about FDA approval. So I've heard anywhere from before the end of the year to the beginning of 2022. I can tell you from yesterday, Peter Marks, if you watch any of the press conferences, he's the guy who's always with the FDA commissioner. He's been there for decades at the FDA. Pfizer has submitted their, full biologic approval. From what I've heard, let me clarify, for 16 and above is what they've, you have to wait for a period of time to get a certain amount of data. So the 12 and above will come later. We're hearing anywhere before the end of the year to early 2022.
Okay, well, again, thank you, Lisa, so much for this wonderful presentations that you've provided us. If there are no more questions going to come through, it's just big thank yous, Lisa.
Well, thank you for having me, and everyone keep up the good work. I certainly think we've come a long way, but I'm a mountaineer, so I'll say we certainly have to keep climbing. But thank you for all that you do to care for kids in our communities.
All right, everyone, we'll see you back this afternoon. Thanks again, Lisa.
Take care, everyone.